Welcome everyone. In the spirit of reconciliation, PKD Australia acknowledges the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respects to the elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today. Good evening, I'm Carolyn Cass and I'd love to welcome you to tonight's webinar, Preparing for a Pregnancy with PKD and What You Need to Know. Our guest presenter tonight is Associate Professor Shilpa Jesudason, an academic nephrologist and chair of the Clinical Research Group at the Royal Adelaide Hospital's Central Northern Adelaide Renal and Transplant Service. Her clinical and research interests include parenthood in patients with kidney disease, and she runs a statewide obstetric nephrology service for preconception counselling, antenatal and postnatal care for women of all stages of CKD and pregnancy. She's also got expertise in consumer and community engagement for kidney disease research, policy and advocacy. Dr. Jesudason is the immediate past clinical director of Kidney Health Australia, and she also co-led the development and the delivery of the National Strategic Action Plan for Kidney Disease, the KHA Youth Program State of the Nation report, and the KHA Yarning Kidneys Indigenous Consultations Program. And without further ado, please now welcome Dr. Shilpa Jesudason.
Thank you very much. I'm going to share my screen. So, Carolyn, is that okay with my slides there?
Yeah, that's come up perfectly.
Okay,
thank you.
Great. So good evening, everybody. Thank you for joining us this evening to talk about PKD and pregnancy. I'd also like to acknowledge the traditional custodians of all the lands that we are on at the moment, and I pay my respect to their elders past, present and emerging. This evening with me, I would also like to welcome Dr. Charmaine Green, who is a member of our Pregnancy and Parenthood Consumer Advisory Group. She has previously held roles with PKD Australia and has lived experience of PKD and pregnancy. So I'm going to go through just a little bit of background about polycystic kidney disease and pregnancy, and then we will hopefully be able to have time for some questions and answers and some discussion towards the end, as well as hearing from Charmaine and her experiences and knowledge. So I just thought I'd start with some house rules and some disclosures and disclaimers. I think it's really important, as I'm presenting some of the information about PKD and pregnancy, that you recognise this is just general information. There are people who are listening. I don't know what your background is and what your situation is, and not all of this information may actually apply to you. In the chat, there is an opportunity to pop in some anonymous questions, and we would love to be able to answer, Charmaine and I would both love to be able to answer questions at the end and facilitate some discussion, but you can do that anonymously if you don't feel comfortable putting your name to a question that could be quite sensitive. I give a lot of talks like this to women with kidney disease and their partners and families, and I recognise that this can be a really emotional and sensitive topic, and if there is anything that we talk about here this evening that is upsetting for you, make sure you do go and seek some support from the team that are around you and supporting you, and particularly your own kidney specialist. Hopefully this may start some conversations with them as well. So that's just a little bit of background, and please keep that in mind as we go on. So we're all here to talk about polycystic kidney disease, and we know that this is a genetic disorder that causes cysts to form and, oops, sorry. Did I just lose that? There we go. That causes cysts to form and ultimately enlarge over time and damage the kidneys. We know that there are two types of polycystic kidney disease. in general, so autosomal dominant and autosomal recessive. Now, it's the autosomal dominant one that is the more common condition, and we know that there are a couple of genes and many gene mutations that can actually cause this. It's important to understand how many potential gene mutations there are when we come to talk a little bit about the genetic testing. So the thing to remember about autosomal dominant polycystic kidney disease is that if you've got one affected parent, the children have got a 50-50 chance of being affected, because the gene is, when it's transferred, is likely to be dominant. And so this has an impact, obviously, on generations of people living with PKD. And I certainly look after, up to 3 generations at a time in my clinic. And so I think we understand the important impact that this disease has on not just an individual, but on whole families, and particularly on the issue of pregnancy and parenthood planning. So when we look at polycystic kidney disease, we know that everyone has this. So by definition, that's what happens with this condition. But it's really important to remember that not everybody gets kidney failure. So we will look after a lot of women who are coming into decisions about pregnancy and parenthood who won't have kidney failure, who may not even have kidney impairment. This usually occurs, if it does occur, it usually occurs at a much later stage of life. So a lot of the women that we're looking after who are thinking about parenthood planning have got pretty good kidney function, even though they've got polycystic kidney disease. But high blood pressure is particularly common, and that can be a problem in pregnancy. And so we do have to do some really careful planning ahead of a pregnancy. So there is a lot of information out there about polycystic kidney disease, and I'm sure that people who are on this call are hopefully aware of PKD Australia and the fantastic support service that they provide. But also Kidney Health Australia has got a lot of information about kidney disease, particularly polycystic kidney disease, and some really good supportive fact sheets about that, and general information about how to take care of yourself when you're living with kidney disease. And we have a renal guidelines group, the CARI guidelines, that have developed some, a few years ago, developed some guidelines about the management of polycystic kidney disease. So there is a lot of information out there. Those guidelines have been put into some consumer versions as well. So, if you're not aware of these resources, please do check them out. So I'm just going to give a basic, quick pathophysiological discussion so that you can understand some of the terms that we're using later on when we're talking about pregnancy and pregnancy risk. So you all may have heard us talk about creatinine. So creatinine is a byproduct of muscle breakdown, and it gets filtered exclusively by the kidney. So we can measure the amount of creatinine in your blood to actually estimate what the kidney function is. Look, it's not perfect. Lots of other things can affect the creatinine, but by and large, it's useful enough that we measure creatinine in everybody when we're trying to assess their kidney function. And there's a normal range that we see in people who aren't pregnant. During pregnancy, the kidney starts to work a lot harder, and the creatinine normally falls, and so that normal range changes. So what might be normal in the non-pregnant person is abnormal in the pregnant person. So that's just a word about creatinine. Creatinine helps us judge or estimate what the filtration capacity of the kidney is, or something that's called GFR. And we use GFR to explain how much blood is being filtered by the kidney each minute. And normally it's about 100 to 120 mils per minute. And we use the creatinine and some various formulas to try and estimate this. The way I would interpret it, and the way I tell my patients about it, is it's like a percentage of kidney function. So if your GFR is 90%, you've got excellent normal kidney function and you don't have to worry. If your GFR is 60% or less, then you have chronic kidney disease. And then if your GFR is really low and you've got not much function at all, less than 5 to 10%, that's when you need to think about starting dialysis, etc. And this little picture here that looks like a bag of worms is actually the G part, that's the glomerulus, that's the filtering unit of the kidney. The other thing that we look at to assess kidney function is protein in the urine. So we look at either protein or albumin, and that's just done with a little urine sample. And normally you shouldn't have any protein or albumin in your urine. It should be completely clear. And we know that when you get kidney damage, that causes the protein to leak out. When you're pregnant, the kidneys are working a bit harder, and as a sign of that, they do leak out a little bit of protein. And that's quite normal in pregnancy, but only a little bit, not too much. So we do watch protein in the urine very carefully as well. So the final thing we look at is the ultrasound. And so many of the people with polycystic kidney disease on this webinar would have had this ultrasound. Now, normally the size of the kidney is about 10 centimetres and should be nice and smooth. In polycystic kidney disease, the kidneys are full of cysts, and the kidneys are really bumpy. And you can see the comparison here of a normal kidney on the left and a polycystic kidney on the right, and that those big cysts actually squish the good kidney and stop it from being able to filter, and that's how people get kidney failure. So we take all of this together and we put people into categories in terms of how good or bad their kidney function is. And there's 5 stages of chronic kidney disease. And I tell you about this because where you sit in this staging is very important in terms of defining pregnancy outcome. And I'll talk about that a bit later. So let's now move to the issue of parenthood and kidney disease. But at this point, perhaps Charmaine, if you could give me a thumbs up if my slides are still looking okay at your end. Okay, wonderful, thank you. So we've done a lot of work in my research group over the last sort of few years to try and understand what other perspectives of women living with kidney disease when it comes to motherhood and parenthood. We've done a lot of interview studies, we've looked at the literature, we have a pregnancy consumer advisory group that Charmaine is part of. And we've done a national survey, and we've been talking to women about what's important to them. And what they've told us is that motherhood is a goal and it's an aspiration. And if because of their kidney disease or other health issues they can't achieve this, then there is a sense of failure and loss at not being able to achieve this goal. So we have to prioritise this as a goal for the patients that we take care of. And women have told us that they have a lot of fears and insecurities about making decisions about pregnancy. You know, what their own health and their own long-term outcomes, worries about the baby, feeling guilty about gambling with their health. And then often there's a lot of medical judgment about the decisions that they're making, and that's not really helpful. And they've also told us very strongly that being in an environment that's supportive of pregnancy and that's positive about achieving motherhood is extremely important. And that's something that we've certainly taken on board in our clinical service. We recently did a survey of women across Australia with chronic kidney disease and transplantation, some of whom did have polycystic kidney disease. And we asked them about, you know, their experiences in terms of pregnancy counselling and outcomes. And this is what they told us. They said that, you know, a lot of them had to actually raise these discussions themselves, so they had to be proactive. And very few of them had, only about a third had pregnancy issues raised very early on in their disease. Often it only came up later when they were coming to a crunch time and they had to make important decisions because their kidneys were failing. There was a real need for information. You know, only 14% of women, it's 14% of women told us they only received information about pregnancy after they were pregnant, which is clearly we've got a lot of work to do there. And a lot of women use the internet or other patients as their source of information. So And this leads to people not feeling in control of their decision making. And we know that that's really important when it comes to navigating to better outcomes. So there's a clear desire for more information, and that's what today is about, is to, get that information out there. We've also done some work looking at all of the different points in that very long journey with kidney disease, from early stage to advanced stage to dialysis to transplant, all of the different points where decisions become really important in that CKD journey. And I'm not going to go through this slide. The point of it is to show you that it's complicated, that there's a lot of decision making that needs to happen depending on what stage of kidney disease you're at. And this is why discussions need to start quite early, and you need to know what's ahead and how to work through all of these issues. And so this means that our counselling about kidney disease really needs to be patient-centred. And I think as patients, this is sort of what you should seek from your care team, that you're at the centre and that you're part of the decision-making, that there's some counselling done before pregnancy, an assessment of what your risk is going to be in pregnancy, that you have an individualised pregnancy management plan, that you get access to genetic counselling and pre-implantation genetic diagnosis if you want it. Not everybody does, but if you want it, it should be there. That when you're pregnant, that we're looking for pregnancy complications and watching you carefully, and then after the pregnancy, some further follow-up in the postpartum period. And wrapping around all of this is the psychosocial issues and just general support for what can be sometimes a fairly challenging journey. And when we ask women what are they most concerned about, they want to know, what effect will kidney disease have on the pregnancy? What effect will having a pregnancy have on the kidneys? What's going to be the effect on the baby? And can I stop the inheritance of polycystic kidney disease? These are the key questions. And the answers to these really depend on where you are in your journey and what CKD stage you're at, what the rest of your health is looking like, and what the rest of your context is like, your perspectives, your social situation, your personal situation, and who you've got around you. So it's not always as straightforward, and that's why it takes time sometimes to work through these things. One size doesn't fit all, and so you should be working with the people who are in your care team, clinical care team, to get a tailored plan that's best for you. So pregnancy is a stress test on the kidney, very early on in the pregnancy, sort of towards the end of the first trimester, the kidney's working 50% harder, the heart's working harder, you've got more blood flow going through the kidney, and you're filtering more. So if kidneys are already damaged, putting them under this stress test can be a bit of a problem. So we need to know where where women are sitting in terms of how they'll be able to take on this stress. We know that the preconception parameters of kidney function, or the GFR or creatinine, protein leakage, blood pressure, and then diabetes and other conditions are the things that are going to determine whether you have a good or bad pregnancy outcome. And these risk factors can all come together to be additive. So this is a fairly simplified chart, but I use it in my pregnancy counselling. I think it's quite helpful because you can say to women that, look, okay, you've got CKD stage 1 or 2. Chances are that you're going to have an uncomplicated pregnancy, but your risks of complications such as your kidney disease progressing, having a preterm baby, developing this problem called preeclampsia, it's increased compared to a woman without kidney disease. As you get to stage 3 and stage 4 or 5, and look, to be honest, we don't have many women with polycystic kidney disease who get to those stages and have a pregnancy. But if you were to get to those stages, you go from having most likely an uncomplicated pregnancy to more likely to have a complicated pregnancy. By the time you're in that red zone, it's likely that there's going to be some pregnancy complications. And so this can help women understand what's the likelihood of an adverse event occurring. Most women with PKD are in that green zone when they come to a pregnancy. And it's really important to emphasise that there's still a good chance of doing well. So these potential risks are not a reason to not progress with a pregnancy if that's what you want. In our transplant patients, this is just an example of a similar traffic light system that we've started using to assist with our counselling. And you can talk women through, look, you've got this problem, so that puts you in the amber zone, but you've got good kidney function, so that puts you in the green zone. And this can just help women understand and contextualize risk. And important to remember that what's considered, what one woman may feel is too risky may be quite acceptable to another woman. So again, your values and your perspectives are critically important and central to how this information is interpreted. So we've talked a lot about risk, we've talked a lot about potential outcomes. So how do we approach management? And I think there's, in my experience, there's two schools of thought, both for patients and for doctors. There's probably a happy medium somewhere in between here. So this is an algorithm that we developed for management of polycystic kidney disease in pregnancy that we published a few years ago. It's complicated because there is a lot to think about, and that's why you need planning ahead, and it's ideal if you can get all of this planning and not have an unplanned pregnancy. But there's lots of things we think about ahead of a pregnancy. Then, once you've decided to go for a pregnancy, some specific planning, managing women through the pregnancy, and then managing them after the baby is born, and then maybe doing a rinse and repeat when you've, when you're going for your second pregnancy. So I'm going to take you through some of these issues. The critical piece of information is to plan ahead, and I think this picture of the sign that says plan ahead really says it all. You don't want to be stuck in that situation where you've kind of like run out of time, run out of options. So getting on top of this early and having these discussions is really important. So there's a lot that we look at when we're planning for a pregnancy with polycystic kidney disease. But again, those three things of what CKD stage are you at, what's your blood pressure doing, and how much protein do you have in your urine, that's really important. The size of your kidneys is probably less important, but whether you have liver disease is also quite important. I think it's always very important to offer genetic counselling to women if they wish to have it, and then bring in any extra people that you need. So, for example, fertility experts or high risk obstetricians and any other extra specialised involvement required, depending on the health problems of the particular patient that we're looking after. And then we have to think about when's the right time to go for a pregnancy when you've got polycystic kidney disease. And that depends on your age and what your fertility is doing, etc. So the best time to have a pregnancy is when you've got stable kidney function, your blood pressure's under good control, your medications are safe for pregnancy. In women with advanced chronic kidney disease who might be facing dialysis or a transplant at some point in the future, that window of opportunity can be tricky because they may not be able to achieve good health after a transplant, for example, until after the window for having a baby, biological window is gone. With women with polycystic kidney disease, because that late stage of the disease comes in much later, we don't face that problem too much, thankfully. The important thing is to keep using some contraception while you're planning and while you're doing this waiting for the right time, because it's much better to have a well-prepared planned pregnancy than an unplanned pregnancy. So part of the reason for planning in PKD is that you do have the opportunity, if you've got a gene that's identified, to have pre-implantation genetic diagnosis. And this is something we can talk a little bit with Charmaine about, because she's actually working in the embryology space. So this does require an IVF procedure to create embryos, and then they get tested for the polycystic kidney disease gene, and then you choose an unaffected embryo for implantation. This does raise the issue about what you do with the other embryos, and there are lots of pros and cons to this process. And it's definitely not for everyone. I've had patients who felt very strongly about doing this. I've had patients who felt very strongly that they would not want to do this. So the key thing is that you're aware of it and that you can seek information about it if you wish. Getting blood pressure control before pregnancy is really important. And there are some medications that need to be stopped once you're pregnant, but it's okay to stay on them until you're pregnant. And then once you're pregnant, you change to special medications that we have tried and true and known to be safe in pregnancy. So once we've got all of those things under control, we put together a pregnancy management plan and then say, okay, off you go ahead and try and conceive. But it's best done when mum's health is absolutely optimised. Once you are pregnant, then that's the time that hopefully your kidney specialist can navigate you to have a multidisciplinary team who specialise in high-risk pregnancy and understand the issues of pregnancy with kidney disease and PKD. And then there's a lot of very close monitoring of mum's health, baby's health, and of the kidney, or if you've got a kidney transplant, of the transplant, and then working out when is the best time to deliver. So we do a lot of looking. We do a lot of watching and waiting and surveillance, watching the mum, watching the baby. And this does mean extra clinic visits sometimes, and it does mean some extra scans and some extra blood tests and monitoring. And we're looking for kidney function going downhill, blood pressure developing, or this problem called preeclampsia, trying to fix anything that can be fixed, such as infections and diabetes, watching the baby and working out when's the best time to deliver, because sometimes the best thing to do is to deliver early for a safer outcome if things aren't going well. We watch blood tests and urine tests and blood pressure. So that's just something to be aware of. And just because you're needing lots of this done doesn't mean that things are going badly. It's just that we like to watch things like a hawk. As I mentioned, blood pressure is very important, both before pregnancy and during pregnancy. It's the one thing that we can actually treat and control. And we just want to make sure that you get blood pressure on target. Sometimes that will require medications, and then we're watching out for preeclampsia. Now, this problem of preeclampsia, or we used to call it toxemia, it's a placenta problem. So it usually doesn't appear until after 20 weeks when the placenta is really starting to kick in. And it can have a bad impact on both mum and baby. So you can get high blood pressure and kidney function, liver function issues in the mum, and you can have a baby that's not growing that well. And the only way to really treat it, despite all of our medical knowledge, is to deliver the baby. So this is something that we watch out for really carefully, because we know that it's going to be hard to prolong a pregnancy if preeclampsia really kicks in. And we know that it's increased in women with chronic kidney disease. We use aspirin in all women with polycystic kidney disease and any kind of kidney disease, because we know that if we can give you low dose aspirin throughout the pregnancy, if we can start that early at around 12 to 16 weeks and continue on in the pregnancy, there's actually a substantially reduced risk of preeclampsia. There's lots of studies that have shown this, and in women who are at high risk. This is not something that every woman with who's pregnant needs, but women with high blood pressure and chronic kidney disease do benefit from this, and it's a pretty safe thing and simple thing to do. Women with polycystic kidney disease can get a lot of back and tummy pain in pregnancy. Back and tummy pain is very normal in pregnancy anyway, okay? So as the body is stretching and getting ready for the growth of the baby and for delivery of the baby. But in PKD, this can be a real problem, because you've often got enlarged kidneys already. There's really not a lot of space in there. You've already got the baby taking up space plus kidneys. And sometimes you can get cysts that are rupture and bleed and cause problems and cause acute pain. And we watch out for infection very closely, because urine infections can go up and infect the kidney, or cysts can get infected. And we need to get on top of that really quickly in a pregnancy. The other thing is that liver cysts may grow during a pregnancy. So if you've already got liver cysts, they can enlarge. And then if you get preeclampsia, that can sometimes cause tummy pain, funnily enough. And then there's a whole bunch of other reasons why you might get tummy pain. So this is just something to be aware of when you've got polycystic kidney disease. When it comes to delivery, a lot of women think they have to have a cesarean section. And actually, that's not true. In fact, our preference would be that you have a normal vaginal delivery, because that's actually the safest and way of delivering and has the quickest recovery. But we do see a higher rate of induced delivery and cesarean sections in women with kidney disease, because often the delivery has to be hurried along earlier than term, because something's happening with mum's blood pressure or with their kidney function, or the baby's not growing, or there's preeclampsia. So we do see a much higher rate of cesarean sections in women with kidney disease. But again, that's dependent on what stage of kidney disease you've got. So again, women with PKD likely to have very early stage kidney disease are likely actually to do quite well, and there's no need to panic about some of these complications. And there's no need for you to not breastfeed if you don't want to. Most of the medications are actually fine for breastfeeding on that we use to manage blood pressure, etc., in pregnancy. So I'm just going to summarise there with some take-home messages. So I think that the really key thing for women listening to this today is that pregnancy with polycystic kidney disease is very doable. Okay, you just need careful planning and careful care during your pregnancy. And that you should start that planning as early as possible. You know, talk to your clinicians, ask questions, you know, get informed with the information you need to make some decisions, and then get your individualised pregnancy plan. And while you're doing all of that planning, make sure that you're not at risk of having an accidental pregnancy where you haven't been able to get those things just perfect ahead of time. And don't be afraid to ask questions. Go to your next clinic visit with some questions around pregnancy. Our pregnancy group's actually developing a checklist of questions that women can take into their clinicians. So yeah, there's a lot that you can do to inform yourself. So I'm going to leave it there and hand over to Charmaine to say a few words. And so Charmaine has been involved in PKD Foundation, has been involved in our pregnancy consumer advisory group for a number of years, and has actually been involved in some of the work that I've presented to you today, particularly around trying to understand what women want in terms of pregnancy education. So Charmaine, I might throw to you just to say a few words about your experiences. Thank you.
Thank you. Hi, everybody. Nice to be back. So thanks for having me tonight. Yeah, it's been really nice experience being on the consumer group for the pregnancy and developing some of these questionnaires and things like that. Really what we do is we share our experiences of what we've had and how we've felt about it. So, I mean, I might just share a little bit about my personal experience with being pregnant and having PKD. So I was one of the lucky ones. My doctor spoke to me very early on about pregnancy planning. And now that I think about it, maybe it was too early, but but it was good. It gave me time to think about what I wanted to do. And he was very adamant to have a baby while I still had good kidney function, which is what I did. So I went into my pregnancies with good kidney function, but I did just having polycystic kidney disease did mean that I was a high risk pregnancy. So I had quite a good experience with the public health system. So my doctor just wrote a letter, and I went into the high risk clinics. So that meant I saw an obstetric doctor each time rather than the midwives, and they just kept a very close eye on my pregnancy. For my first pregnancy, because I had a family history of aneurysms, and they did do a few extra checks. So they, and I'm not sure if this is routine or not, but for me, they just did a brain scan and a scan of my aorta. So that really did put my mind at ease going into the pregnancy and labor, because you do have all these fears about like, what if you're under a lot of pressure giving birth and things like that. But the pregnancy went quite well. I did end up developing preeclampsia, although I wasn't on any aspirin medication. So that happened in both of my pregnancies, getting this preeclampsia. And it just meant that, with my second pregnancy, I was induced. So I did start seeing those spots, and I didn't really think much of it. But then I went into the clinic the next day, and they took a wee sample and saw the proteins were elevated, and then rushed me in, and I was induced. But so that was like, I've got 2 healthy kids now. One we know has PKD, and the other I'm just not sure yet. I haven't done any tests on her because she hasn't had any symptoms. My son did, and he had problems when he was quite young as a baby with a urinary tract infection and a few other issues, not growing so well, but he's doing really well now. So we're just monitoring it, keeping an eye on things. Definitely doing better than when he was a baby. So what else to say? One thing that did surprise me after having my second baby, I developed something called postpartum preeclampsia, which I wasn't expecting at all. So that's when the preeclampsia sort of went away for a couple of days, and then it shot back up, and then it wasn't, a midwife picked it up when she came for an at-home visit. So she measured my blood pressure and said, you're going back to hospital. So went back to hospital and was on blood pressure medication until they could get everything under control. But yeah, the healthcare system, that in my experience, worked really, really well at keeping an eye on things. And I think they did a really good job at managing my pregnancy. So that's my experience. I was working with PKD Australia previously, and I just went back to my previous job as an embryologist. So now I'm working on the other end. We do the genetic testing of embryos, and so I'm also happy to answer any questions you might have on that from an embryologist perspective. And I didn't choose to do it, but I know a lot of people do. And then, yeah, my other experience is being on this consumer group, and it's really exciting to see all the support that Shilpa's developing, and really being able to inform doctors and of what patients want, which is really important, advocating for our needs as patients. So thanks for letting me share my experience, and I might throw back to Shilpa.
Charmaine, thank you, and thank you for all the work that you do with our team. So I can see that we've got some questions on the chat. So I might just address some of these. So someone's asked about where else there are equivalent centres specialising in PKD and pregnancy, and I think we've got a special service in South Australia, which is essentially just my clinic and a couple of other clinics that we've started around the place. A lot of kidney specialists will navigate their patients through this themselves, but working with high-risk obstetricians, etc. So I think there are some units around Australia that have got specialised obstetric nephrology services. Other units don't. So it's a good starting point to just ask your kidney specialist, where's the best place for my care to occur, and is there somewhere that in your town that specialises in this area? And often there is. It's a growing area of interest, and lots of people are getting interested in this space. Somebody else has asked the question, is pregnancy more likely to cause a further reduction in your GFR when it's already lower? And that's a really interesting question. By and large, if you've got good kidney function going into the pregnancy, it's very unlikely that your kidney function will take a hit with a pregnancy. Where we're more concerned is women who've got more advanced CKD, so maybe stage 3 or stage 4. where we know that those women, about 80% of them will come out of a pregnancy with worse kidney function than when they went in. But it doesn't always have to be that much worse. And actually, surprisingly, very few women end up on dialysis during a pregnancy, even if they've got quite poor kidney function. So it's yes is the answer. You can have a hit to your GFR, but not always. And for some women, they're happy to accept that risk. They're happy to accept a small decline or even a major decline in their kidney function if that's their window of opportunity for achieving a pregnancy. I think that someone's asked about whether you should, if you've got PKD and good kidney function and no other issues, should you consider a pregnancy earlier just in case? And I think that's really a personal decision for most people. The older you get, the more likely you are to have kidney impairment, blood pressure problems, etc. But again, if you're not ready or wanting to have a pregnancy at a particular time, then that your kidney disease is not a reason to go ahead just for that. So these are complex decisions that you've got to make, but I think you keep talking to your kidney specialist about what's your future likely to be, and then work out the best timing of pregnancy when it comes, taking all of that into account. In terms of age range to have a pregnancy, if your kidney function is currently good, again, it's the same sort of answer, which is there's, obviously as you get older, your fertility does decline, and particularly after the age of 35. So if you are wanting to have an easier pathway to pregnancy, going earlier is probably better. Charmaine, did you have any other comments you wanted to make about pregnancy timing and some of your decision making around that? Oh, sorry, just need to unmute.
Yeah, I do think it's can be quite personal depending on your factor. Working in the fertility space, like I knew that about my fertility potentially declining after like 35, as you said. So I never wanted to go through IVF myself, seeing what a hard journey it is, because it can be. So I did want to plan this, my pregnancies earlier, and that's what my doctor recommended, given my family history. But I think like now I'm coming to like the whole thought process again. So going through that cycle of, well, do I want to have a third pregnancy in the future, and what would that do for my kidney function? So yeah, I'm still in that thought process of you never really know. Yeah, so I'm just not sure.
I think that that does sum up the uncertainties, and every person that comes through my counselling service, we have these sorts of discussions, and people choose different pathways, and that's why that planning is so important, so that you've actually got time to think about these things. I've taken, I've seen women over maybe 2 or 3 years to help them plan this journey, because it can be quite fraught. There's a question here from Paolo. Hello, Paolo. Lovely to hear from you. Is it likely that early PKD symptoms correlate with complications during pregnancy? And the answer is no. It's really the kidney function, blood pressure, and urine protein, those same parameters. People get a variety of symptoms irrespective of what their kidney function is actually doing. So I can reassure people that even if you do have some pain and symptoms, it's not necessarily correlated to a bad pregnancy outcome. And then Charmaine, there's a question here for you about why you chose not to have genetic testing.
Tough question. It was definitely a personal decision at that time in my life. I think now, like if I was to do it again, I might change my mind. So it was just at that time in my life that I didn't necessarily want to. I think if I was going through IVF anyway, I would do it. But at that stage, like that wasn't necessary for me in my journey to becoming a parent. So that's part of the reason, but not, yeah, it's just, for me, like, I just think in my family's progression, in my mind, like no one was sick yet in my family. So I hadn't seen those effects, but now like my dad started dialysis and I'm really starting to see more of that, what it is like living like with PKD, whereas that reality wasn't there for me as much when I was younger. So my decision making could be completely changed in the future. So it was just at the time of my life, and but I definitely don't have any regrets to how I did things.
I think that's a very very similar story to a lot of people that I've looked after as well. You know, having said that, I've had a couple of patients who've been absolutely adamant that they want to go down this pathway to eradicate PKD from their family. There've been a couple of studies done on this topic, actually, interviewing people with PKD about genetic testing. And it's definitely been shown that that there's a variety of opinions and often quite strong feelings about this. From my perspective, I think it's critically important that every woman with PKD who's planning a pregnancy knows that this is available, and that they make an informed decision that's based on their personal priorities and preferences. I think it's and that's for so many things around pregnancy planning. I think one of the hardest things for me to listen to as a clinician, what frustrates me the most, is when I see women who say, I wish I had known that I could have done things differently, or I could have done things earlier, or I could have made different decisions or had different options, but nobody ever discussed it with me. And really that's our mission, is to try and turn that around so that every woman with kidney disease actually has the opportunity to be in control of what happens to them around their reproductive outcomes. There was a question about whether there will be a recording, and yes, I believe there will be, but someone from PKD Australia may wish to comment on that, but we certainly did this a couple of years ago, and that recording is up on the website as well. So hopefully this one will be. Are there any other questions from the group or from people who are online? It doesn't look like there are. So I'd just like to take this opportunity. Sorry.
I was going to say, I might ask a question.
Yes, please.
With kidney disease, is there any evidence with going through IVF if that can affect, because of the hormone stimulation? Is there any evidence of that affecting kidney function at all?
Yeah, so again, this is something that needs to be planned ahead of time. In general, no. And particularly if you've got reasonably good kidney function. We do worry about something called ovarian hyperstimulation syndrome, where there are very high estrogen levels, and that can sometimes make women unwell, and that can cause some kidney problems. But that's pretty rare, and it's something that I usually just work with the IVF specialist to plan an appropriate IVF treatment for each woman based on their particular kidney disease and particularly blood pressure issues. So it's something that we're aware of. We don't see it that commonly, and we do see a lot of women who have IVF, and most of them actually do just fine with IVF treatment. Okay, and then further to Charmaine's question, high estrogen levels accelerate cyst growth at all? Yes, they can do, not necessarily for the kidneys, although there may be some small effect. It's not really been well studied, but we do know that estrogen affects liver cyst growth, and particularly things like the oral contraceptive pill and being pregnant can increase cyst growth. So it's just something to be mindful of, particularly if you've got a lot of disease burden from liver cysts. Again, is this it's not a reason to not pursue a pregnancy, but it's just something to be aware of and include in the we should include it in our counselling of women with PKD. Okay, so I think we've come to the end of our questions and to the end of the webinar. I'd like to thank everyone who's online for joining us this evening, and thank you to PKD Australia for again giving a spotlight to this topic and supporting the work that we do, and particularly thanks to Charmaine for coming along tonight and bravely sharing her stories and her insights. So thank you.
And thank you again for answering those questions as well, Shilpa. We really appreciate your time, and that was a really comprehensive discussion, and you put a lot of time and effort into that. So we really appreciate all your perspectives and all your insights on that. And a big thank you to Charmaine also for joining us tonight and providing your interesting perspectives on your journey as well throughout pregnancy. So a recorded version of this webinar will certainly be available soon on the PKD Australia website in answer to that question earlier. And also, if you'd like to receive any other information in regards to this pregnancy webinar, feel free to send us an email at PKD Australia, and we can always forward that to to Shilpa as well. So thank you again for joining us tonight. Take care, and we hope that you will join us for our next webinar soon. Bye for now.